Today we have Michael Kuczynski giving us a talk. Michael did his undergraduate degree at University of Calgary in electrical engineering, and he did some of his undergraduate research work in Dr. Sarah Mansky's lab, including some work on automatic segmentation of subchondral bone in the knee. He continued in Dr. Mansky's lab for his PhD, which he started in 2018, and he's planning on graduating and defending next year sometime. So his research is focused on medical imaging, image processing, and osteoarthritis. He's also interested in developing open code for musculoskeletal imaging. And to that end, he's part of the ORMIR community and has made contributions to the Python ITK library. So some fun facts. Michael recently ran a 50K trail ultramarathon and is also interested in hiking and road biking. But today he'll be talking to us about some of his PhD work, the use of static and dynamic CT imaging to better understand the structure-function relationship in hand osteoarthritis.
Awesome. Thanks for that introduction. I hope this mic isn't too loud. Thanks to everyone who attended in person and virtually. So I'll start off with a bit of background. I'm sure many of you are familiar with osteoarthritis, but if you're not, it's a degenerative joint disease that affects synovial joints. It affects all synovial joints, but most commonly we see it affecting the knee, small joints in the hand, and the hip. And it's a disease of the whole joint, so we see the bone being affected as well as synovial membrane and other parts of the joint. And we don't fully understand its etiology. However, we do know that it is a multifactorial disease. So we see involvement from genetic factors based on your age, ethnicity, your sex, as well as the mechanical environment of the joint itself, which is a primary focus for my PhD work. So moving into the hand, it commonly affects three main joints, being the distal and proximal interphalangeal joints, located at the top in that figure there, as well as the trapeziometacarpal or TMC joint, often called the first carpal metacarpal joint as well, which is located at the base of the thumb. And radiographically, we can characterize osteoarthritis by osteophyte formation, so the presence of these bony spurs that develop on the edges of the joint surface, as well as sclerotic bone and cysts, and narrowing of the joint space, which is really just a measure of the cartilage degeneration, as we can't measure cartilage using X-ray-based imaging. So in particular, the TMC joint is of interest in hand osteoarthritis, as it is a very uniquely shaped joint, a mechanically complex joint, and some studies have even provided estimates of this joint providing about 40% of the hand's entire functionality. So that could be for gripping different things or pinching and so on. So another interesting fact about this joint is that it can experience very high peak loads. I believe about 10 times the force that you would exert at the tip of your thumb can be experienced at the TMC joint. And like many other joints, mechanical instability, whether that's ligament laxity or the shape of the joint itself, can lead to the development of osteoarthritis. And there have been several interesting studies recently that have been published that have shown that the morphology of the TMC joint changes in early stages of osteoarthritis, as shown in the figure on the top there, as well as tracking the volume of osteophytes that form in the TMC joint over a 3-year time point, as shown in the figure on the bottom there, and seeing how that increases. And while we can see that there are clear structural changes to the joint in osteoarthritis, it's not quite clear, at least from a quantitative perspective, how that affects the function of the joint. So looking at the structure and function relationship in osteoarthritis, there's this really interesting cycle you can see here, pulled from this review paper from 2011, that shows that we can have changes to the structure of the joint, which can then affect the function of the joint, and we can have this cycle of structure affecting function, and those effects can be from various things, like I've mentioned, ligament laxity, changes in the bone structure, dislocation of the joint, and so on. And what's really interesting is that we can see a lot of these structural changes radiographically before any symptoms are actually appeared. So like many other diseases, it is always better to catch disease in its early stages so we can better improve the treatments and outcomes of the disease. Looking at some more advanced imaging beyond just regular clinical CT, we have access to a high high-resolution peripheral quantitative CT scanner over at the Mojo in the Foothills Hospital, where we can actually look at some of the bone microarchitecture, primarily the trabecular and cortical bone microarchitecture, and look at some of the microstructure of the joint rather than looking at things like statistical shape modeling and overall bone shape. And we also have this dynamic or 4D CT protocol available in some of the clinical scanners over at the Foothills Hospital, where we sequentially obtain three-dimensional CT volumes over time. So we can get something like a video like you see in the bottom here. And this is limited to, based on the gantry rotation. Depending on the scanner you have, you might have a larger field or longitudinal coverage area to scan, as well as faster gantry rotation, allowing more frames per second. But we do have some limitations, being large data sets. So we have multiple 3D volumes over time. So that can add up to quite a long processing time if we don't have any automated tools available. And the radiation exposure as well is increased from a clinical CT scan because we have a longer scan time. But we do have potential to image some joints that we cannot image with traditional motion analysis systems like motion capture using infrared markers. And a TMC joint is a great example of that, where it's very difficult to actually place those skin markers on the joint because of its location and size. So something like dynamic CT can allow us a view into quantifying the function of the joint. And what's really interesting, I think, is there are some dynamic CT or 4D CT papers out there, even for the TMC joint, but it hasn't been used to date to look at osteoarthritis or these types of diseases that can affect the function of the joint. So I'm going to go through three studies now. First being a pilot study that we performed looking at hand osteoarthritis and evaluating joint space parameters and bone mineral density using that high resolution scanner I mentioned earlier. And the objective of this study was to, as I mentioned, look at some of the joint space and bone mineral parameters using HRP-QCT in a cohort of osteoarthritic women and healthy age and sex match controls. So the motivation behind this study is primarily from this study group for extreme CT and rheumatoid arthritis, which is this international collaboration that developed this workflow to look at joint space in rheumatoid arthritis patients using HRP-QCT. However, this hasn't been applied to hand osteoarthritis, at least to my knowledge, and it can provide some really useful information on how the joint space changes in osteoarthritis. So some questions that we had doing this study, first being, we have several joint space metrics, which I'll get into in just a moment, but which of those, if any, are relevant in hand osteoarthritis and related to some of the clinical outcomes that we have? And are any of these metrics significantly different between hand osteoarthritis and controls? So this workflow that I mentioned is developed using the scanner manufacturer image processing language called IPL. And basically what the Spectra group did is they had three different methods from Calgary, France, and San Francisco. And they all had slightly different approaches to looking at the joint space and quantifying some of the joint space parameters. And what they did is they combined them into one consensus approach to be used everywhere consistently. But we had to make some changes to that, which I'll get into in some of the methods here. In terms of our recruitment, we had 10 women clinically diagnosed with hand osteoarthritis in the DIP 2 and 3 joints, as well as the TMC joint, and 10 age and sex match controlled. And we looked at, we had each participant complete the diseases of the arm, shoulder, and hand or DASH questionnaire, which looks at the disability, ranks the disability of their hands, as well as a functional test called the Jepson hand function test. We had our scans performed at the Mojo at the Foothills campus, the Extreme CT2 scanner with those parameters you can see there. And we scanned the 2nd to 4th DIPs and the TMC joint, but only analyzed the 2nd and 3rd DIP as well as the TMC joint. However, due to the size of the TMC joint, we weren't able to actually capture the joint in one single image. So we actually had to obtain two, what we call stacks, with a 25% overlap, and then use image registration to combine those into a single joint image. In terms of the data analysis, these are the parameters that we looked at. So first we had our bone mineral density, which was taken as using the first 100 slices of the distal and proximal bones. We didn't have the full length of each bone to get like a percentage of each participant's bone to look at bone mineral density. So we just looked at the first 100 slices. And for our joint space analysis, we looked at joint space volume, the mean width, the standard deviation of the width, the minimum and maximum of the joint space width, and the joint space asymmetry, which is just the ratio of the joint space width maximum to minimum, and is really just a metric for looking at subluxation in the joint or a dislocation in the joint. So we basically used that Spectra workflow, but we had to re-implement everything in Python. It started off just by improving the stack registration, which I'll show an example of in the next couple of slides. And one thing led to another, and we ended up redoing everything and improving everything in Python. And this is openly available on the GitHub link at the bottom there, if anyone wants to use this. So once we have our TMC joint and our DIP joints as a single image, then we have this automatic contour segmentation. And then from that segmentation, we can do our joint space analysis and calculate our bone mineral density. And just for the sake of time, I won't go into the details on how that is done. For statistical analysis, the joint space width and bone mineral density parameters were compared between groups using a Wilcox and rank sum test. And then we correlated our HRP-QCT outcomes to our clinical outcomes using a linear regression. And all stats were performed using R. And this is just an example of the registration issue that I was talking about. We had a lot of issues with some of the scans where the registration clearly wasn't working. We were losing parts of the bone, and there was what we call the stack shift artifact, which you can kind of see at the top here. But using some Python and simple ITK, we were able to get much better images, at least visually. We didn't do any quantitative analysis for this, but you can quite clearly see this is a much better aligned image. And the way this works is very similar to what was done in the Spectra workflow, where we take the 25% overlap between images, do an intensity-based image registration, and then use the transformation matrix as output from that to transform the proximal stack into the image space of the distal stack. And in some cases, we still do see a misalignment or stack shift artifact, but is much more improved compared to the IPL method. For our joint space width analysis, we did have to omit 2 scans of the DIP3 joints due to severe joint degeneration, which prevented us from actually analyzing some of the joint space, as you can see in this example here. And just some quick results on the DASH and Jepson hand function test. As expected, we found the OA group had higher DASH scores, which indicated lower or greater hand disability, and their hand function test times were higher as well, so indicating that they had worse hand function than the control group. And now looking at our joint space width and bone mineral density parameters between our healthy and our OA group, we found everything in bold is with a p-value that was significant, less than 0.05. But what was interesting here is I have highlighted the DIP3 joints, and specifically the joint space width volume, mean, standard deviation, and max. We found were significant. And the reason I've highlighted these is because when we went into our comparing our clinical outcomes to our HRP-QCT outcomes, we again found the exact same parameters in the DIP3 joint. The volume, mean, standard deviation, and max had significant correlations between our clinical outcomes and our HRP-QCT outcomes for both DASH as well as the Jepson hand function test. And these were all positive correlations, meaning that higher, for example, for joint space width volume, higher volumes were correlated with higher DASH scores in our OA group. And that may not be completely intuitive, but if we look at some of our images, we can start to see that this does actually make sense. So in a lot of these OA participants, we did have more luxation or dislocation of the joint. So that led to higher maximum values in our joint space, lower minimums, increased joint space volume, and so on. And as I mentioned, the Jepson hand function test was also positively correlated with the same values that I've been showing, minus the joint space width mean. So while these correlations are quite weak and our sample size is quite small, this does suggest that maybe these are the parameters that we should be looking at in a larger study, and something that warrants further investigation going forward. One issue we did have is that just by design, the algorithm that we're using to actually quantify the joint space doesn't detect a joint space width value of 0 when there is bone-on-bone contact. So we've used an automated connectivity filter to determine when there is and when there isn't bone-on-bone contact. However, that leads to some other issues. When we're actually calculating our joint space with asymmetry, we're dividing by our joint space with minimum. So if we do use this, then we have values that aren't defined. So it's possible we may need a different metric if we want to have some sort of quantitative measure for joint luxation. And we still don't really know whether the bone-on-bone contact that we're seeing is true bone-on-bone contact, or if this is just an issue due to image segmentation or some other artifact that we're seeing. So we applied this modified joint space width workflow to these osteoarthritic and control DIP and TMC joints. And what was really interesting, again, I'll highlight here, is that we found significance in our DIP3 joint for these following joint space width parameters. But it is interesting that we didn't see any significance really for our TMC joint, but that could be just due to the sample, the participants rather, that we had. So this is an example of some TMC joints from a control and from an osteoarthritic participant. And you can clearly see that the control has some radiographic evidence of osteoarthritis. But we just recently have had some hand surgeons go through and score the radiographs for our control and osteoarthritic group. So we can see whether we have any kind of explanation as to why we're seeing the results that we're seeing for the TMC joint. And for the BMD analysis, we didn't see any significance again, but we're looking at a regional analysis, particularly in the TMC joint, as we know that the articulating cartilage and the underlying bone can change at different aspects of the joint as osteoarthritis progresses. And what's also interesting is that the method we're using for computing bone mineral density is actually taking 100 slices in the axial direction, which may not be ideal, as we'd prefer to go 100 slices in a normal direction to the joint contact surface. And in later slides, I'll discuss how we're looking at automating that. And one final discussion point here is the image segmentation. So the standard image segmentation technique that's used on these HRP-QCT scans may work fine for the knee or a larger joint, but we see issues in some of these smaller joints, as you can see here, where we're over-segmenting, over-thresholding our underlying trabecular bone. So we might actually be missing some of the trabecular bone here when computing our bone mineral density. And we'll probably need to come up with a slightly different approach to that for the hand joints. So now I'm going to jump into some work we've done with dynamic CT or 4D CT. And this paper was actually just recently accepted for publication this week. So that's great news. And the objective of this we're developing a processing pipeline for these dynamic CT scans of the TMC joint. As I mentioned, the processing times can be very long due to this data size, and we really do need some automated tools. And now that we've developed this pipeline, we wanted to evaluate the repeatability and reproducibility of this pipeline for computing joint motion, that is joint angles and translations, as the method that we were using to set up segment coordinate systems was manual. And the motivation for this work was, again, the large processing times, or long processing times rather, and the need for open source and automated tools. There are some workflows out there in published works that use multiple different softwares that you'd have to pay for, and it can just make things very, very difficult. And we weren't sure what sort of errors we were expecting for the workflow that I'm about to present here. So in terms of what's currently out there for dynamic or 4D CT, it's hard to find people reporting how long it actually took them to process anything. But there is one study here from 2018 that said it took them 120 hours for a single TMC joint movement for a single participant. So you can clearly see that if this is going to be used in any sort of clinical study that with a larger sample size, then you definitely need some more faster automated tools. And a lot of the studies have been limited to characterizing healthy joints, looking at cadaveric work and validation of different methods, or qualitative measures like the example I have on the right here of a clenched fist, looking at joint instability. So in terms of the methods for the study that we performed here, we had 10 cadaveric specimens from the University of Calgary. They were all right hands, and we developed this passive motion device using a 3D printer, a servo motor, and an Arduino Uno to move the thumbs in a radial abduction-adduction movement or a functional flexion extension, as you can see in the video there. And we scanned it using a clinical CT scanner at the Mojo, which has a dynamic or 4D CT protocol with the parameters listed there. Unfortunately, we're limited with a slice thickness of 2.5 millimeters, which can really impact our image resolution. There are newer scanners that have improved or smaller slice thicknesses available and longer longitudinal coverages. Here we were limited to 40 millimeters, so we weren't able to capture the full TMC joint. So we had to get a little bit creative with our scanning. And because these were cadavers, we decided to put them in the Extreme CT2 scanner and scan the entire TMC joint, which took a very long time. Definitely something we couldn't do in vivo. And we use this as the basis for our image segmentation and selection of landmarks to set up coordinate systems and then compute joint motion. And we use image registration to move this information into our dynamic CT images. So we're really just using our dynamic images for the position of the joint and using the high resolution images for actually segmenting and selecting landmarks. But we did find that the drastic resolution change between our HRPQ-CT and dynamic CT was a bit too much for our image processing to figure out. So we actually added an intermediate step where we scanned the entire hand in the clinical scanner, same one as the dynamic CT was performed on, just to have an intermediate step to help the image registration accurately line up the bone masks. So this whole workflow was developed in Python, and we processed each bone individually and then combined them back together into a joint image in our dynamic CT space. So the image segmentation first was done, as I mentioned, in the HRPQ-CT space. And this was done using some global thresholding and morphological operations. It was mostly automated, except for cases where the bones were too close together and we needed to manually delineate one bone from another. And then we have this viewing software that I developed for selecting our landmarks for a coordinate system of each bone. And this is using a landmark configuration that was previously described for the TMC joint. So next we have three different sets of image registration, first being from our high resolution scans to our static CT. This was done by selecting 3 landmarks in both images for aligning the images for initialization. And then we have an intensity-based image registration, which then spits out a transformation matrix, which we can then move our bone masks from the high resolution space to our static CT. And the exact same process is performed from that static CT to the first frame of our dynamic CT. And you can see the resulting first metacarpal mask moved there. And then finally, to move between all of our dynamic CT frames, we had about 60 frames per cadaveric specimen. We use a sequential registration approach that used the information from the previous frame to initialize the registration. And this way we can move all of our landmarks and our bone masks to every single dynamic CT frame. And then from there, on each dynamic CT frame, we have the computation or the setup of the segment coordinate system for each bone, and then a joint coordinate system was used to represent joint motion, again using a previously described method from 2009. And to assess our reproducibility and repeatability, we had 3 raters select landmarks on the high resolution CT models, and then 1 rater select the landmarks in 3 separate trials. And each rater was given a document that outlined where they should be placing these landmarks and had some examples showing those as well. And then we looked at, we computed the interclass correlation coefficients for our joint angles, as well as a root mean square error for our joint angles to look at the differences between the coordinate systems set up by the raters and how that affects our resulting joint angles. We also implanted 3 glass beads into the first metacarpal of one of the specimen to look at how much error we're actually seeing from the image registration rather than differences from our raters. So we did this with a target registration error computation by looking at the centroids of each of these beads and then looking at the difference between each of our image registration steps. And then the last thing I'll mention here for our methods is we further evaluated our image registration error by looking at the difference between each segment coordinate system axis between each set of raters and looking at how that error changes in our dynamic CT image space. So ideally, we would see For example, a 1 degree error in our x-axis for our first metacarpal between two raters, and we would ideally want that same 1 degree error to be consistent in our dynamic CT space. Looking at some of our results, these are some sample plots from one specimen for our abduction, adduction, flexion, extension, and axial rotation angles. And as expected, we see better intra-rater agreement than inter-rater agreement. Looking at our joint angle interclass correlation coefficients, again, we see better agreement between a single rater rather than between the 3 raters, and greater variability between multiple raters. Looking at our joint angle and translation root mean square errors, we see somewhat similar pattern minus the abduction, adduction joint angle root mean square errors were a little bit higher for intra-rater. And for our registration evaluation, we found the target registration error was at or below voxel level for each set of our image registrations. And our segment coordinate system orientation error was less than 1.3 to the negative 11 across all specimens, so very small. This is kind of giving us confidence that the errors we're seeing are actually due to the differences between raters rather than some of our image processing. So while we did see fairly low errors for this method that I proposed here, we are able to automate the segment coordinate system definition rather than using manually placed landmarks. And this is something that I've been working on, almost completed at this point. But basically what we do here is if we extract the joint surface of our trapezium and first metacarpal and fit a polynomial surface to that, we can find the saddle point, in this case of our trapezium shown here, and find a normal vector at that saddle point, and then use the principal directions of curvature to define 3 vectors or our segment coordinate system. However, it's not really clear whether we can use these automated techniques or if it's better to use something manual when we're talking about joints that are affected with osteoarthritis. And we know we can see in the case of the trapezium, flattening of the joint surface and formation of osteophytes along the edges as well. So using this approach as well, we're able to get that normal vector at our saddle point, in this case for the trapezium, which then allows us to actually split up the TMC joint into different quadrants. And then we can, from there, analyze changes in the bone at different aspects of the joint where we know, for example, in the case of the trapezium, that in the volar ulnar aspect, we see thinner articulating cartilage as osteoarthritis progresses. So then we can start to look at some of the underlying bone changes in those areas. So we've also started to look at joint proximity in the TMC joint. And this is just a nice figure showing from some cadaveric specimen at different stages of osteoarthritis, where where the cartilage begins to thin first. So using some values from literature, we're actually able to calculate a bone-to-bone distance to get estimates of our joint contact area. And then from there, we can even look at things like joint stresses. So this is just some preliminary work of the TMC joint showing the joint contact area. The red areas indicate where we have distances less than 1.5 millimeters, or the summation of the estimated thickness of the first metacarpal and trapezium cartilage thicknesses. And then on the right here, we actually have some code in MATLAB that's from Dr. Don Anderson and his group at the University of Iowa, where they're able to look at contact stress during, in this case, the ankle joint of someone walking, and how that changes during movement. And this is just a quick video of contact area changing on the trapezium during one of the cadaveric specimen adduction movements I showed earlier. However, in the ankle, we use the force of the body weight as our force for contact stress, but we don't have that in the TMC joint because it's a non-weight bearing joint. So instead, we have some equations from this paper from a few years back that actually gives us equations and some cartilage properties and values that we can use to estimate the contact stress, and then we can look at how that changes in different aspects of the joint during different clinically relevant movements for osteoarthritis. So just to conclude on this work here, we've developed this workflow. It drastically reduces the processing times from at least what I can find in literature. It takes anywhere from 1 to 2 hours, depending on the speed of your computer, which is great. We found low errors from image registration. So that means that the errors we're seeing are likely due to rater biases rather than our image processing, which is great. And then finally, we're looking to move, we are moving and have begun a study looking at in vivo joint biomechanics in healthy and osteoarthritic women, which I will touch on briefly in the next couple of slides. However, because we had cadavers in this study, we were able to use that high-resolution CT scanner, which gave us really great high-resolution images of our TMC joint. But we can't really do that in vivo because of the radiation exposure, and the scanning time would mean there's lots of motion in our scans. So instead, we have this new cone beam CT scanner, this weight-bearing CT scanner, which we can position to scan the hand as shown in the image on the top there. And we get a great, it's a great image to do our image segmentation, where we're using this new graph cut segmentation technique, so slightly different from what we've currently proposed here. So quickly going into this study that we're currently recruiting for and I'm currently working through now, is assessing the relationship between the joint structure and function in women with hand OA using dynamic CT and HRPQ CT. So here we want to look at some of the bone microarchitecture using HRPQ CT and use the dynamic CT in the workflow I've shown here to look at some of the joint function, quantitatively measure some of the joint function, and also compare that with some of the clinical outcomes that we see in hand osteoarthritis. So the motivation for this work is, as I mentioned in the introduction, that the use of dynamic CT in osteoarthritis literature is lacking. I expect that to change pretty soon. There's a lot of papers starting to come out now using dynamic CT for different diseases and conditions, specifically in the wrist. And to look at some of the as I mentioned earlier in the introduction as well, some of these radiographic changes, these structural changes that we can see in osteoarthritis tend to happen before any clinical signs, such as pain. So for this study, we're recruiting 3 different participant groups, all women, first being looking at 15 women with TMC osteoarthritis. And for that, we're looking at Eaton-Littler stages 1, 2, and 3. Ideally, we planned on using earlier stages of osteoarthritis, somewhere where we may not see symptoms, but we do see radiographic evidence. However, that is very difficult to recruit. So we've kind of broadened our recruitment a group there to include the 3 different OA stages. Second group is our age and sex matched control. There are healthy controls, and finally young healthy controls, just to look at characterizing what normal healthy movement in this joint would be using dynamic CT. For our clinical outcomes, we've switched from using DASH and the Jepson Hand Function Questionnaire as in that first study to using the Michigan Hand Outcome Questionnaire. This covers a lot more than either of those 2 questionnaires cover. So there's things like occupation, function, pain, and so on, and also has a normative data set available, which should be useful when going through this data in the future. And finally, we have some functional measures that we're looking at. So range of motion in different joints in the hand, mechanism of injury, and different signs and symptoms, whether there's swelling or other deformities that are present. For our scanning, we have quite a bit of scanning in this study. So we have our HRPQ CT, or high resolution scans, but in this case, we're not capturing the full joint, just 3 stacks of the TMC joint. And we get an image that looks something like this at the top after registration. We've replaced the full HRPQ CT image with this cone beam CT image, where we're doing our image segmentation as shown here. And then we have our 3 dynamic CT movements here rather than just one like we were performing in the cadaveric study. So we have, again, the radial abduction adduction, but now we've added 2 more clinically relevant movements, being thumb opposition to the base of the pinky and a lateral key pinch, where we're having the participants actually put pressure and force down during that pinch. And then finally, we have some regular radiographs for scoring by a radiologist. So these are just some very, very preliminary movements of a young healthy control and an osteoarthritic participant. I need to do some tweaking on some of the image processing. As it turns out, going from HRPQ CT to weight-bearing CT or cone beam CT makes a big difference in the pipeline. But what is interesting here is that in the osteoarthritic participant, you can kind of see that there is a little bit of bone-on-bone contact happening during this movement, and these are both the radial abduction adduction movements. So it'll be really interesting to see how the actual joint angles and some of the other measures like joint proximity change between the three groups that we have here. So I also have a plug here. We're still recruiting for this study. So if anybody knows someone who fits in any of these categories, or you are a woman between 20 and 40 with no TMCOA and would like to get scanned, we have about a 2-hour study visit over at the Mojo, and we greatly appreciate it if anybody is interested in helping out with this study. Yeah, these are my acknowledgements. There's a lot of people who have been involved in this study since I've begun my PhD. I'd like to thank. And with that, I'd like to thank everybody else who attended here in person and virtually, and I'd be happy to take any questions you might have. Thank you.
So we're going to open this up to questions.
Michael, in the last slide or a couple of slides ago, you showed like a bouncing bones.
Yeah.
What can you just show me what that movement was?
That was a radial abduction adduction.
Do you think it would be better if you fixed the trapezium?
Yep.
And then,
Yep.
and so if you
So,
do that, does
yeah.
it show?
Yeah. So the bouncing that you're seeing here is actually because the initial registration from the weight-bearing CT scan to our dynamic CT scan isn't perfect. I'm not sure why the change in resolution between this study and the previous work changes that registration results so much. But then if that registration doesn't align the bones properly, that's going to affect every single other frame going forward. So that's why we start to see a little bit of the bouncing there. So that needs to be tweaked a little bit. But yeah, it's fixing the motion is relative of the first metacarpal relative to the trapezium. So we could just fix that trapezium as well, like you were saying.
So you basically have developed the methodology, correct?
Yeah.
And the final goal is to understand something about osteoarthritis.
Yeah.
Osteoarthritis.
Yeah.
And you said that it's important to understand joint angles.
Yeah. Yeah, I'm looking at the
joint angles to develop osteoarthritis. Can you explain to me how you are going to do that?
How we're going to actually like quantify the joint angles, or?
No, not how you're fun. Let's assume you have
Yeah.
joint angles. But how are you going to do that? You try that you understand osteoarthritis better by knowing the joint angle.
Yeah. So what I'm looking to do is use, in this case, joint motion or joint angles as a measure of quantifying the function in the joint. So that's why we have the movements like opposition.
But it's function. Big terms. I would like to see how you go from joint angles to development of osteoarthritis.
Right. So primarily what I was interested, but has been difficult to recruit, is earlier stages of osteoarthritis, where there are no clinical symptoms, but we do see radiographic changes. And what I was hoping to see is that we do see maybe some functional changes by looking at changes in joint angles between healthy and osteoarthritic or early stage TMCOA, and looking at even more specific.
Yeah, what are functional changes?
Well, I'm talking about like in terms of the joint angles, or functional, like clinically. You mean either or? So clinically, I mean things like having impingements, grinding happens in later stages. In early stages, there might not be anything, but the hope with this work is that if we actually get something quantitative, that there might actually be changes in those measures from the imaging, rather than doing some clinical measures like seeing if participants can move their thumb in different positions or through different motions.
So
that answers the question.
Correctly, you hope that you will find some differences in joint movement
Yeah.
between the two groups.
Yeah.
And then you would conclude that this is related to the development of osteoarthritis.
That it could be related to the development of at least if we have clear signs that there is radiographic osteoarthritis.
But you don't know at the moment which functional change.
Yeah, so I haven't been able to find anything in the literature. As I mentioned, nobody has really done any of this kind of dynamic imaging in osteoarthritis. So, I mean, you can look at some like gait analysis or things like that, how that changes in osteoarthritis, or some other motion analysis literature, but at least for the TMC joint, there isn't really much there. We do have some studies that have looked at more static imaging and have shown changes in cartilage or bone at different stages of the disease, but in terms of anything quantifying actual motion, there isn't too much out there.
Maybe just follow up a bit.
Yeah.
How do you define osteoarthritis? Clinical people would define it by the symptoms, but you're talking about osteoarthritis when somebody doesn't have symptoms.
Yeah, radiographic.
So so what's radiographic evidence?
So
And, and if I have no function impairments and no symptoms and no nothing, can I really call it osteoarthritis?
Yeah, that's a good point. In terms of the TMC joint, they use this Eaton-Littler classification here that looks at things like joint space narrowing, presence of osteophytes, sclerosis, things like that, and different sizes of the osteophytes, different amounts of joint space narrowing. So we would say Eaton-Littler stage 1 and 2 would be more the early stage where you may not have symptoms. And even in some of the earlier work I've shown here, in that pilot study that we had some age and sex matched controls which were supposed to be healthy, but if we looked at their scans, there's clear radiographic evidence that there might be osteoarthritis there.
So in the knee, I don't know anything about the TMC joint. I think I've heard people talking about the knee joint and saying that radiographs are a very bad predictor of symptoms. Is that similar in the TMC joint, or is that much better? And you see more and more, you also get more and more symptoms. You see more evidence of OA on your radiographs, or on your micro CT, you also have more symptoms.
Yeah, so at least from my experience in some of the scoring we've actually had some hand surgeons do for some of our controls, we would have people even with stage 3 and 4 radiographically, but were not clinically diagnosed with osteoarthritis. So I guess it's kind of similar to the knee in that case, that you may not have symptoms if you have the radiographic evidence.
So in the knee joint, some people have argued that loss of muscle strength is actually a more powerful indicator than radiographs.
Yeah.
Is that also true maybe for the hand, that loss of strength in the hand is?
Yeah, there is evidence of loss of grip strength. We are doing measures of grip strength in the study this last study I've shown here, but I haven't gotten to any of that data yet. I can't recall anything in the literature talking about changes in muscle strength. I know there is evidence of laxity in your ligaments, which can then lead to some of these structural changes as well by changing the function, but I can't recall anything in the literature about changes in the muscles.
Talking about lax joints, it's going to be my last question.
No worries.
Talking about lax joints, we have this thumb apparatus where we do work with this adductor pollicis. And some people, about 1 in 10 people, we cannot use for these experiments because when they push really hard against here, their joint slips out. And so is that a bad problem for these people? Is that what you call subluxation, when that joint slips out? Because
so subluxation or luxation is just a dislocation of any joint, really. Usually when we're talking about like rheumatoid arthritis or osteoarthritis, and you look at the radiographs, you can see that the joint is, I don't know if I have any examples, but you can clearly see that the joint is not well aligned. I think I have some images in the very beginning. But yeah, it's essentially like a dislocation. So I think here you can see this image is actually flipped. The first metacarpal is on the bottom, but yeah, it's basically just like a dislocation of the joint. Yeah.
When you have osteoarthritis in the KNC joint, you can have a bad day and then good weeks and good months.
Mm-hmm.
And I'm wondering if that would be reflected in the joint space. And so, you know, when I'm fully hydrated and not having a good month, it's big. And so if you take this, so I guess I'm wondering, do you do longitudinal measurements of this? Because if you have a single point in time, and in fact, there's a distribution, that unless you know how big the distribution is, you actually don't know whether the individual measurement, you know, whether it's this end or this end, and so firstly, have you done longitudinal and say, you know, if I'm in pain, does it mean it's tighter? And when I'm having a good month, and I'm hydrated. Have you done anything like that?
I haven't done anything like that. I did have plans to use MRI to look at some of the cartilage and actually maybe get some cadavers to get better estimates of the cartilage thickness in this joint for some of the later analysis that I wanted to do. I haven't gotten to that, and I don't know if I'll have time, but that is a really good point. And yeah, it can depend, like you said, if you're having a good day, if you're maybe positioned differently, a lot of this joint space stuff can change. In terms of the analysis that was done for rheumatoid arthritis and that we've also done for osteoarthritis, the hand is placed in the same position between participants. So we could kind of hope with the same positioning that we can have more consistency between our participants that way. But as you said, we haven't done anything longitudinally to look at days maybe you're more hydrated or not.
Because if you took a single measurement and then, you know, a week later you took another single measurement, you actually cannot say whether you've had improvement. Because they might have been from the same distribution. But at the very beginning of your talk, you said as justification, if you catch this early, you'd be able to influence the outcome. And so if you were to see this sort of pre-symptomatically or something or other, is there something you can do to adjust the outcome by seeing it early?
Yeah, so that's a good point. Ideally, you want to prevent. You may not be able to prevent the disease from getting to end stage, but maybe you can prevent things like any surgeries that may need to be performed. So at least in things like knee osteoarthritis, there was a presentation a couple weeks back at the McKeag Institute about using exercise to maybe change. I don't know if you were at that presentation, but so things like that. So you know, using maybe different splints or maybe even some kind of exercises could be used in the hand as well.
Is there evidence that exercise in the early stage is going to
there's nothing I've seen. There's nothing that I've seen. I can say that repetitive movements, not necessarily high-loaded movements, but repetitive movements are not good. But I haven't seen anything for any exercises. I would assume strengthening your muscles would help in the hand, help with stabilizing the joint itself. So that might be something that could be done, but I haven't seen anything in the literature myself.
And the last question, do I get it that you've only done these in women?
Yeah, so these have all been done in women because they have a higher prevalence of osteoarthritis in that joint. Yeah.
What is it about these specific joints that predisposes them to OA as opposed to like, is it just that they get used a lot?
So they're responsible for a lot of, as like I have in this study here, 40% of the hands function, and it's unique shape as well. So it's kind of concave on one end, in one direction, convex in the other. So it can get high peak loads, and then if you have instability in the joint, whether that's due to weakness in your muscles, laxity of your ligaments, or whatever, that can affect where your peak loads are, and that kind of predisposes this joint to developing osteoarthritis.
But I just want to follow up on that, because in the finger joints, if you go to the next slide,
Or this one, yeah.
So why are those distal joints affected and not the more proximal one? What do you think is the difference there?
Yeah, that is a good point. I know for the MCP joints there that are more commonly affected by rheumatoid arthritis than osteoarthritis. Off the top of my head right now, I don't think I could tell you, but
well, maybe nobody knows ours.
Yeah, they do have the DIPs, I believe, might even be more common than the CMC joint or TMC joint. But in the case of the TMC joint, it has a lot to do with the mechanical properties of the joint.
And there are familial trends with particular joints as well. Presumably that means anatomic.
Yeah. So for like rheumatoid arthritis, MCPs 2 and 3 are, I'd say, the most common. And you'd see less involvement of the 4th MCP or something like that. And similar for, osteoarthritis.
So why are you looking at OA and not rheumatoid? Rheumatoid is more common, isn't it? Or,
I don't know what to say really. That's kind of where my project started when I started my PhD, was looking at no, I guess. I know osteoarthritis is well, this is just the instance of knee, hip, and hand OA. Hand is very common, but not as much as knee OA, obviously.
Is hand OA coupled to limb OA as well? Like if you have hand OA?
It actually is, yeah, which is really interesting. So it's one thing I might have left out here, but so things like having osteoarthritis in your knee can actually increase your chance of getting TMC OA. Even being obese can increase your chance of getting TMC OA. So that's why I mentioned here that it's multifactorial, because it's not completely mechanically due to mechanical factors. Yeah.
It's also this discussion. I'm wondering if hand dominance has something to do with incidence of disease, more OA in the dominant hand than the non-dominant hand. Are you looking at both in your current study?
In the current study, we're just looking at dominant hand. And it's really interesting. A lot of the literature in hand osteoarthritis is quite conflicting. So in terms of hand dominance, there's some studies saying that the non-dominant hand has a greater incidence of osteoarthritis, some saying the dominant hand does. And the same with things like occupation as well. Some say that your occupation does affect development of osteoarthritis, and some say that it doesn't. So there's a lot of conflicting literature out there on that. I would assume that hand dominance does matter, and that your dominant hand would have greater risk of developing osteoarthritis. But what I can say to that.
So what's my dominant hand? I'm writing with my right.
Yeah.
I throw with my left.
Oh, okay. I think they chose the hand that you most commonly use for most activities, or for like working. Yeah.
And I'm left-handed, but I was forced to write right-handed. But now, because I was forced to write right-handed, I do a lot of small tasks with my right. And I brush my teeth and I shave with both my hands. I can go like that and like that.
Interesting.
But I'm really left-handed. But I was taught to write right-handed, but I think that transferred then. Now I do a lot of small, fine tasks with my right hand as well.
I wonder if that's studying some of the data, because left-handed people tend to have to do a lot of tasks right-handed, or they're taught right-handed because they're taught
Somebody
That's
was
interesting.
here once and talked about handedness, and it was a very interesting talk, I thought. And his argument was, this is many years back, but his argument essentially was, there is right-handed people and people that are both-handed. Then when they're born, they kind of decide to become left or right-handed. But he argued there's actually no left-handed people. You're either, kind of a
Interesting.
multi-handed, you choose one, or you're right-handed. I have no idea where that came from, but I remember that
Interesting.
statement. So anyway.
Well, I don't want to stop this conversation about handedness. So if there's more questions on that, you are going to have to start harvesting fat rat hands now. I'm interested in the nuance between sort of what Don has been doing at the lower limb versus what you want to do. I think we've talked about this before, but it's not really coming to me. So he gets people to step into the weight-bearing CT, right?
Yep.
And what do they just stand on one leg or something, or bilaterally? And so he assumes that there's a certain amount of force that goes through the ankle.
Yeah, using their body weight.
Okay, and so I understand that you don't really know the force that's going through the thumb joint.
Yep.
But I'm wondering why the force is even necessary. Like even in Don's setup, you got the proximity map.
Yep.
You assume there's a cartilage thickness.
Yeah.
Something. You assume there's a modulus of elasticity. You get the stress.
Yeah.
So what is the force needed for? Because at the end of the day, doesn't he just report stress anyways?
Yeah, they reported stress over time, as like what that video is showing there.
Whereas here you're going to have the proximity maps.
Yeah, I have the proximity maps, and then there's this paper from a few years back that looked at the contact stress distribution in a static scan. I think it was for one of the hand joints. I think it might have been the TMC joint. And these are the equations they used. So a lot of this, the variables there came from previous literature on cadaveric specimens. So like cartilage property. And then they assumed that uniform thickness, and then looked at how that thickness or that overlap changes depending on the position.
The only thing that I can think of is that if you knew what the force was, you wouldn't have to assume what the modulus of elasticity would be. You could directly calculate it because you have the proximity map and you have the stress. But Don doesn't report differences in modulus of elasticity.
Yeah, they just use the body weight from the MATLAB code I've looked through. I haven't taken a deep dive into that code, just enough to generate this figure here. But I'd have to take a deeper look into what exactly his code is doing.
Right. Might it depend what you're more comfortable with, assuming the elastic modulus or the cartilage thickness. Because you could also argue that I don't know the cartilage thickness, that I just assume the modulus and have the force. And maybe I could get a thickness, or I could get the elastic modulus if I assume the cartilage thickness.
Yeah.
Yes, it depends what you feel more comfortable. So I thought with micro CT, there's a way of also getting cartilage thickness.
Yeah, we can. And one thing I should also point out is that it is very thin in the TMC joint. So whether if we're looking at earlier stages of OA anyway, it might not even matter if we're assuming uniform or not. We did try a pilot scan on one of the MRI scanner in the Siemens Center to look at the cartilage in the TMC joint in vivo, and it is very difficult. It would make image processing very, very difficult because of how thin the cartilage is in that joint. So one of the things I did hope to do, I don't know if I'll get to, was actually just using some cadaveric specimens and measuring the thickness that way, using that as like getting one healthy cadaveric specimen and one with known osteoarthritis, and using those two maps as kind of like the way to estimate cartilage thickness in those groups across all the participants. But we'll see if I can get to that.
Can you check?
Yeah,
Can you do that?
yeah. Our ethics currently don't have that in it, but you.
Did the if it's a cadaver?
Oh, in the cadaveric work, yeah. Yeah, we could do that as well. But yeah, that study was, I guess, somewhat complete, but we could get some more specimens and
Maybe not you.
yeah, maybe not me.
Okay, and you're, okay, Rob?
There's an inflammatory component to osteoarthritis. I'm wondering which comes first, inflammation and then causing closeness, closing up of the joint space and causing damaging circumstances, or damage leads to inflammation. So which comes first? And if you were going to take a measure, if there's an inflammatory variable in there, and you were doing it in live people instead of cadavers, whether you could give an anti-inflammatory medication 12 hours before doing the assessment to try and eliminate that variable.
Yeah, so at least in the case of the TMC joints scoring here, if you look at stage 1, you can actually see that the joint space is a lot wider than any of the other stages, and that's often because we see more of a swelling of the joints. So you actually see joint space increase a little bit, and then in later stages kind of collapse in. So that's where that inflammation kind of plays a role in there.
What actually swelled? What
so I've seen in literature people suggesting that it's the actual like effusion of the joint, I believe, and then get inflammation of the synovial capsule as well.
Are there joint replacements for finger joints?
Yeah, so there are. There's a few different surgeries that they can do. Some of the more extreme ones, they would actually remove the trapezium altogether, and they can even fuse the joint, and they can have replacements of the trapezium as well, partial or full. So there's quite a few different things they can do depending on the severity of the disease. Yeah.
What's the, like, I understand with 40 cm you're sacrificing a lot of resolution. So what's the benefit of doing that rather than just taking a couple static images of some full?
Yeah, so the argument for that is that if you're just doing maybe like one position and then say, for example, fully extended or something like that, you might be missing some small subtle changes in the actual joint motion through that movement rather. So there has been a study, I think, that's only done healthy controls, and they looked at static stepwise CT, and they suggested in their limitations that it may not be suitable for disease joints like those affected with osteoarthritis. And while we do sacrifice a bit of spatial resolution, as you can see in some of these images, some of the newer scanners actually have a decreased slice thickness and increased longitudinal coverage. So one of the scanners that we wanted to use in the Foothills Hospital that's used clinically has a, I think, 0.625 millimeter slice thickness rather than 2.5 millimeter, which is what we have, and has a 16 centimeter longitudinal coverage rather than 4 centimeters. And I think 16 is the largest you can get on any scanner nowadays. So there are other scanners that have better spatial resolution. We just didn't have access to it because of COVID. So we just used the one that we had. Yeah.
I wasn't going to ask this because it's a little speculative, but it builds off what Michael asked. Do you think that there's like, you're going to be able to identify a set of maybe like critical positions for people, or do you think it's going to be so different among people that you really do have to do the whole 4D every time?
So you're saying that if we could just maybe do a few static positions, or if actually having the full movement.
I know you definitely need the full data to identify if there's static positions, but I'm just asking you to speculate. Do you think there's going to be like specific positions that it turns out these are the ones that are really important?
Yeah, I think there will be. I think there will be, depending on the type of movement you're doing, the peak loads will be at different parts of the joint. And I think some of those may be the critical positions that you might be talking about. Haven't seen anything in the literature for the static imaging to suggest any critical positions. But yeah, I
You might
think
be able to find it, right? If you,
Yeah.
If you say that it's always in that movement, it's this angle that's really dangerous.
Yeah.
Lots of people, then maybe in the future that's the only.
Yeah, then maybe that's the only one you actually need. Yeah, it could be.
Do we know why women are more affected by hand OA than men?
Yeah, so it comes down to hormone levels, as well as there has been some studies that looked at congruence of the joint in men and women, as well as bone size. I believe women had higher peak loads in the TMC joint, at least, than men, and things like congruence as well. So how well the joints actually match to each other can affect it as well. So yeah, those are some of the main things.
That's a unique question. How often do you get post-traumatic OA in the hand? Does that happen a lot?
Yeah, so it can happen. How common it is, I can't really say off the top of my head. But yeah, it definitely can. Yeah.
I have some bone questions. And one of them is, I know you didn't quantify it, but are you able to actually see sclerostic subchondral bone using the HR PQCT? And like in your first study where you compared controls to.
Yeah. There's one there. There's a TMC joint, yeah. So is that kind of what you were looking for?
Well, do you see thicker subchondral bone in the OA? I know you didn't quantify it.
Yeah, we haven't quantified that. I mean, just looking at these images, the control here definitely looks worse than the matched OA participant. But now that we have some scoring of these, I'm going to take a deeper look at the TMC joints, because we are seeing kind of mixed results for some of our statistics on the TMC joint, at least in this study.
Don Anderson just texted me. He says, "Nice to hear my name once or twice this afternoon." The last question I have is, we talk about the obesity epidemic all the time. It's an influence on OA, but 50% of women with knee osteoarthritis have osteoporosis and they're small petite, and maybe even more than 50%. Do you see the same thing with hand OA? Do you see a correlation between low bone mineral density at other skeletal sites in hand OA, or small stature in hand OA?
That I don't know off the top of my head. I can say that I believe there's been a study that looked at the size of the joint and how that affects the peak loads. And I think that was one of the reasons they looked at men and women, and they said women had smaller joints and they experienced higher peak loads. But I don't know off the top of my head anything looking at bone mineral density and stature or anything like that. Yeah.
Frank, you know what Frank always said, like where people who have backbones and he doesn't like do surgery on them. Do you know? He claims that red-haired people with red hair, he always has bad outcomes. And he told me to talk to other people and confirm that, like other surgeons. I have no idea. But he was very he was very serious about that.
All right.
So maybe there's a link there.
Yeah.
Maybe.
But that would mean that movement and speed movements are not that important.
No, hair color is.
That's true. Forget about biomechanics. Go into hairdressing.
The hair performance lab.
Hair or HARE.
Yeah.
All right, do you have any more questions? If not, let's thank Michael again.